All right, well, thank you so much, everybody, for being here. National Public Health Week is finally here. We've been promoting it and being very excited about it. A big thank you to Dr. Angie Buckner for her leadership and vision for National Public Health Week at SJSU, along with our fellow Career Explorations Committee members, Dr. Marcel Dugan, Professor Catherine Doyle, Dr. Josh Bauer. I'm getting nervous. The PHR Career Explorations Committee has planned several exciting events to coincide with the American Public Health Association's National Public Health Week. And this year's topic is Public Health is Where You Are. So first, I want to also thank Professor Melissa McClure-Fuller and her students for allowing us to take over her class time today. And again, thank you to everyone who has taken time to be here with us. It is with great pleasure that I introduce our keynote speaker, Dr. Tony Iton. Dr. Iton is the Senior Vice President of Programs and Partnerships at the California Endowment. His department is responsible for the development and execution of the California Endowment Strategic Plan to help achieve racial health equity in California. In the fall of 2009, he began to oversee the organization's 10-year, multi-million-dollar statewide commitment to advance policies and forge partnerships to build healthy communities in California. Prior to this role, Dr. Iton served as both the director and county health officer for the Alameda Public Health Department. And in addition, Dr. Iton is lecture faculty at UC Berkeley in Health Policy and Management and the co-author of Advocacy for Public Health Policy Change, an Urgent Imperative. And Dr. Iton just shared with us that he has a relationship with SJSU, a long-standing relationship with SJSU. So let's give Dr. Tony Iton a warm SJSU welcome.
Well, thank you so much, Vicki. Should I start or okay, jump right in? All right, great. Well, it's wonderful to be here electronically, as these things are these days, and so I assume that was a warm electronic welcome. So I feel your electrons coming through. And I'm just going to jump right into this because what I want to do today is actually get through a presentation which takes you on a little bit of a journey through sort of public health and understanding a different way of understanding where health comes from. And after we have that kind of journey together, I hope we can get to some interaction and talk a little bit, because that's the most fun part for me. So I'm going to share my screen here and find the right buttons to press here, and then I need somebody to tell me if they can see my slide, and it looks everything is good. Okay, great. All right, so I entitled this talk Inequity, Place, Policy, and the American Social Contract. And I'm going to touch on all of those things. And it's meant to try to understand kind of how we approach health in this country and where we may have gone astray. So I'm going to jump right into it and sort of present a couple paradigms that you have undoubtedly heard about because you've been in public health training, and for me, it was in medical training, and we were taught that health is about people who smoke and drink and drive without seatbelts and have sex without condoms. And our job was to try to change their behaviors so that they had adopt healthier behaviors. A second paradigm is that health is transactional, that it's really about the quality of healthcare. And, the better doctors you have, the better insurance you have, the better your health is. And the third paradigm is that health is genetic. And somehow we're dealing with some sort of bizarre lottery. And some people get good genes, some people get bad genes. And our job in sort of the health space is to kind of attend to those who got dealt a bad hand. All three of these paradigms are framed at the individual level. We're talking about individuals behaving badly, individuals having or not having good health insurance or good doctors, individuals having or not having good or bad genes. And I want to argue to you that all of these frames are slightly right, but so slightly that they're essentially wrong. They don't explain the major phenomena that we see in health. in this country, and certainly not in this state. And I'm going to argue to you that health is in fact political. And notice that the P there is a small p. I'm not talking about Democrats and Republicans. I'm talking about a definition of politics, which is really the struggle over the allocation of limited and precious social goods. And note that this is a struggle. And it's about, at the end of that struggle, an allocation of resources. And those resources may be things like having a park in your neighborhood or a full-service grocery store. Those are health protective resources that are ultimately allocated in political decision-making processes. And communities that lack power, that lack representation, are much less likely to get an equitable allocation of those health protective resources. So if health is political, power matters. Power matters at the individual level, at the family level, and at the community level, most importantly. So what we're talking about when we say health is political is that it is not subject so much to technocratic approaches. And instead, we have to look at democratic approaches. And that's a major paradigm shift that I'm going to try to present to you. Okay, I'm going to start by just trying to shock you into some sort of alertness by reading you this quote. I will say then that I am not, nor ever have been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. Some of you may know that that was Abraham Lincoln, the great emancipator. And many of us have been to the Lincoln Memorial up on the Capitol, and we've seen carved into what I presume is marble, the walls of the Lincoln Memorial, the second inaugural address, the Gettysburg Address, but we don't see Lincoln's overt white supremacy carved into the walls of the Lincoln Memorial. And you have to ask yourself this question: why not? Lincoln went on to talk about how the country was at risk from the integration of Black people into the society, and that the creation of so-called mixed breed bastards could threaten essentially the well-being of the white race. So I show that to you, A, to kind of, again, shock you into some sort of alertness, and B, to present this notion of narrative. Narrative is ultimately the root cause of many of the health challenges we're facing in our country. These problems are solvable. And that's been demonstrated in country after country. In the United States, we have elected not to solve these problems in favor of essentially leaning heavily into one of two narratives. And I depict this narrative struggle in this slide with the right side, which is the darker narrative, which is really the Lincoln / Trump narrative. It's a narrative that says that some people matter more than others, and that our society is really designed to benefit those people and not others. And in fact, we should be excluding others from the benefits of society. And on the left side, I depict a narrative of inclusion, which is essentially one that says our diversity is our strength and that our fates are inextricably intertwined. And the story of this country, and it's not unique to this country, and it actually predates this country, is a struggle between these two narratives. And whichever one of these narratives is in ascendancy dictates the policies that are produced, and those policies create conditions. Okay, so I've summarized everything I'm going to say. Now I'm going to delve into that for you. We live in a world of themes: income inequality, mass incarceration, student protest on campus, refugee crises, Black Lives Matter, Moral Mondays, Indigenous people's rights, Standing Rock, undocumented people struggling for justice, anti-Chinese racism. All of these efforts have a theme that runs through them, and that theme is exclusion. These are communities that are pointing to the fact that they're being excluded from the full consideration, the full benefits of our society, and they're being othered. And being othered means that they're not being able to avail themselves of the full spectrum of opportunities in our society. Now, the narrative of exclusion, and I gave you sort of Lincoln's version of it, does three things. The first thing it does is it intentionally dehumanizes the target. Our former president talked about Mexican Americans bringing drugs, bringing crime. They are rapists. As he announced his candidacy for the presidency of the United States, we've heard about makers versus takers, the Chinese flu, welfare queens, crack babies. These are all very intentional narrative devices to dehumanize the target of that narrative. The second thing that a narrative of exclusion does is it exaggerates the notion of scarcity. And it argues essentially that we live in a world of warring tribes, competing tribes that are fighting for limited resources. And in fact, the United States is just a collection of tribes. And there's some tribes that deserve essentially the spoils and other tribes that do not. And the third thing that the narrative of exclusion does is it defines America very narrowly, and it looks to the past nostalgically, and it looks to the future with fear. Narratives are extremely powerful motivators of behavior. And I just want you to stare at this slide for a second and think about what's in the minds of the folks in the red hats. What's motivating them? It's not facts. It's a story of who belongs. What's motivating somebody to climb the walls of the US Capitol? To scale those walls, to breach the US Capitol, and to wave flags, to desecrate that Capitol, to break open offices and desecrate our leaders' belongings. What is in the heads of these people? Just think about that for a second. Narrative is an extremely powerful motivator. What's happening in Ukraine right now is driven by a narrative, a story, a false story, mind you, and many narratives are false. They're fact-free. They don't stand essentially a challenge when you bring them up against the facts, but they're very, very powerful. This is 2010, this is a former Senator, Arlen Specter from Pennsylvania. It's a moderate Republican who believed in universal health care. When the Affordable Care Act came out, he went and had town halls in Western Pennsylvania, and he was confronted by constituents who brought guns to town hall meetings because they thought that affordable health care, universal health care, was a threat to their tribe. So they armed themselves and showed up at public town halls to try to shout down this Republican senator. Okay, I told you there are two narratives. The other narrative, which I depicted as the sunny narrative, is a narrative of inclusion, and it does three things as well, slightly different things. The first thing it does is it changes the narrator, and it lets people tell their own story. It lets immigrants, undocumented folks, African Americans, formerly incarcerated people, Chinese, LGBTQ, folks that have stories of their own experiences that are universal stories, that we can see our shared humanity when we hear those stories. The second thing it does is it broadens the lens, as I mentioned, to show that our fates are inextricably intertwined, and highlights the fact that we actually live in abundance. Not that we need to waste precious resources, but we have enough for everybody. And it also looks at the past realistically. It acknowledges genocide of Native Americans, slavery, the incarceration of Japanese Americans, the mistreatment of women, the mistreatment of LGBTQ, the exclusion of the Chinese, and all sorts of horrible historical actions taken in the name of the United States. So those are the two competing narratives. I'm going to put that aside for a minute and now talk a little bit about place. And I grew up in a very lovely city, not in this country, with wonderful parks, great housing stock, wonderful outdoor cafes, a state-of-the-art public transportation system. This is Montreal, Canada. Looking down on McGill University in the foreground here from Mount Royal, where Montreal gets its name. And you see downtown Montreal and then the St. Lawrence River in the background. Canada has a very strong social contract. It's got universal health care for all Canadians. Regardless of your immigrant status or whatnot, if you're in the country, you've got access to health care. Universal dental care for children, a universal childcare benefit, paid sick leave and vacation for all employed Canadians, state-of-the-art public transportation in most of the major cities, highly subsidized post-secondary education. I went to a world-renowned university, McGill, for free. I didn't pay a cent to go to McGill University. I could have gone to McGill Medical School for free. High quality community resources, parks and sports leagues and the like. Now, when you're assessing a country's social contract, which are essentially those policies that anticipate need and provide essentially a safety net for people when they inevitably need that particular service or resource. When you're looking at a country's social contract, just look for one word to assess the strength of it. And that one word is universal. Universal means that there is shared solidarity across groups in that country, and people see their common humanity and recognize that we all have needs and that we can all pool resources to address those needs in a way that allows everybody to do better. I left Montreal to go to medical school in the United States. I went to Johns Hopkins Medical School, and Vicki had asked me to talk a little bit about my career path, so I will. I showed up at Johns Hopkins in the middle of the HIV epidemic, in the middle of a homicide epidemic in the 80s, and was toured around East Baltimore and saw scenes like this. East Baltimore is where Johns Hopkins Medical School is located. So these are scenes immediately adjacent to the medical school. You don't have to go anywhere. You can walk right out the doors of the medical school and you're in East Baltimore. And I had never seen anything like this before. I was being toured around by an upperclassman, and he saw this look on my face and he asked me, "What's wrong with you?" And I managed to stammer out something to the effect of, "When was there a war here?" Because it looked to me like what was happening in the news in Beirut. Piles of rubble all over the place, buildings that were blown out and boarded up, cars that were burnt out and standing on jacks, and garbage up to your knees, and mangy dogs running around, and babies playing in and amongst all of this. And I just couldn't understand what I was looking at. And I'll never forget what he said to me. He looked at me with this look of utter disdain, and he said, "What did you expect? It's the inner city." And I thought to myself, wow, I should have expected this. This is my fault. I should have assumed that this is a normal feature of an American city. And having grown up in Canada where we don't have inner cities, I couldn't understand why this would be something that I should expect. And I asked myself, well, what if I had grown up in East Baltimore? I grew up as a Black man in Montreal, Canada, with two Black brothers. And had I grown up in East Baltimore, would I have been able to be on the same trajectory that I've been on in my life? I mean, this kid, for all intents and purposes, is me. And this kid had no hand in creating the environment in which he grew up in East Baltimore. He has to navigate this environment every single day of his life. He had no more hand in creating this environment than I did in creating the environment I grew up in Montreal, Canada. Yet, what do we owe this kid as a society? Because this kid gets a message every single day of his life that he doesn't matter, that he is devalued, because he sees it in the environment that he has to navigate. And these kids are not stupid. They recognize that. They internalize that. It becomes confusion. And as they become adolescents, it becomes this raw kind of anger and frustration. And as they get older, what I saw in East Baltimore was people would just check out. They just couldn't take it anymore. They would just check out, and they wouldn't make eye contact with you. They would just do the bare minimum to get by, because they were in this sort of like just glazed over state of just feeling that they had been pushed to the side and were invisible. It's not just Baltimore, Maryland. Years later, I had some opportunity to do some HIV/AIDS work in southern Indiana, and this is a place called Austin, Indiana, which is in Scott County. And southern Indiana, for a while, had the distinction of having the world's highest HIV incidence rate, higher than sub-Saharan Africa. Scott County was gripped by an opioid epidemic. People were grinding up this drug called Opana and injecting it and sharing needles and transmitting HIV and hepatitis C. Scott County is 98% white. And to my mind, East Baltimore and Scott County were the same phenomenon. These were the black and white faces of the same coin, income inequality. And these were communities that were made vulnerable, put in harm's way by the lack of a meaningful social contract. And so people were left to their own devices when a crisis happened, and a crisis like HIV/AIDS, or a hurricane like in Katrina, or COVID-19, or a foreclosure crisis. All of these things hit these communities harder in a very predictable way, so predictable that you can map it, which I'll show you in a few minutes. Because we have essentially created social vulnerability. We've placed people in harm's way by not investing in a social contract. And so the question really for me was, what is the American social contract? And well, I actually don't know the answer to that. I mean, I have a pretty good idea. If we were in person, I would ask some of you to describe it to me. And I know what you would say because I've asked it often enough that I've heard all the answers. But just ponder on that for a minute. What are those universal policies that we invest in as Americans in anticipation of, inevitable need across our society? And, why is it that we seem to have fewer universal policies than other developed countries? Okay, so I left Baltimore and medical school with this question in my head, which was, in the United States, when it comes to your health, does your zip code matter more than your genetic code? And I promise you, I would show you how I tried to prove that. I ended up in the San Francisco Bay Area. For those of you who don't recognize it on a Google map, that's San Francisco. San Jose is down at the bottom there of sort of the bay. And this is Alameda County, which is shaped like a big boot. And I became the health officer and health director of Alameda County. And when you're the health officer, you're the registrar of all births and deaths, which means that every death certificate has your signature on it. And every death certificate, and about 10,000 of them every year in Alameda County, tells you what somebody died of, their age when they died, their race, ethnicity, and where they lived. And you can take those 4 data points, and we did, in 400,000 plus death certificates over a period of about 50 years, and analyze patterns. One of the things you can do is take the boot, which is Alameda County, and look at every census tract or neighborhood and calculate on average how long somebody could expect to live in that neighborhood. We did that in the green areas. People living in those neighborhoods could expect to live routinely greater than 80 years. People living in the red neighborhoods can only expect to live to about 74 years or less. And between the red and the green are the yellow areas where people could expect to live between 74 and 80 years. Now, this map, as you can see, you don't have to be a rocket scientist in public health, but you do have to be able to spot patterns every now and then. And you can see clustering of those red areas. In this particular map's case, you see them clustering in East Oakland and the Flatlands, in West Oakland and the Flatlands, and some of the Flatlands of Berkeley, and then along the I-80 corridor, along a number of unincorporated areas in Alameda County. This map got a lot of attention. It ended up on the front page of the San Francisco Chronicle. It fed into a couple of documentaries, including one called On Natural Causes that played on PBS, and another one called Weight of the Nation that played on HBO. And it was this notion that essentially, give me your address and I can tell you how long you're going to live. Your zip code predicts your life expectancy. And the question is why? Why does that happen? And some people thought, well, maybe this is a unique phenomenon to Alameda County. So we actually went around the country and worked with health departments all over the place, replicating this study. This is Baltimore, which has life expectancies in some neighborhoods of 58 years and other neighborhoods approaching 90 years. This is Cuyahoga County in Cleveland. This is New York City. This is Seattle, King County, Los Angeles, Minneapolis, St. Paul, Boston, Philadelphia, San Antonio, Texas, Denver, Cincinnati, St. Louis, Chicago. Everywhere we looked, we found life expectancies on the differences in the same city between neighborhoods on the order of 15, 20, 25, 30 plus years in cities. We didn't find anywhere where there weren't any significant differences. And we're still looking. I'll show you some more data in a minute. This is the American pattern. This is how we stratify opportunity in this country. It's by where you live. We push people, typically based on their income and their race, into areas of relatively low opportunity because we consider them to be less valuable. And we do this through political processes, through policies and institutional practices. This is how we stratify opportunity in this country. And it's very uniquely American. Not exclusively, but this is the way we do it. And so if you're a data nerd like I am, and hopefully some of you on this webinar are, you like to do these little tricks with the data. On the upper left, you've got life expectancy by census tract, as I showed you. And you can take, on the bottom right, you can take poverty, household poverty by census tract, and you can correlate those two things. Those are the two maps, but you can also do a similar thing. This is COVID case rate and life expectancy. But back to life expectancy and poverty, this is a bivariate correlation, very simple. Each blue dot is a census tract in Alameda County, and as you move from left to right, you're moving from relatively wealthy neighborhoods with low poverty to relatively poor neighborhoods with higher poverty. And you see life gets correspondingly shorter in a very predictable way. The slope of that line tells you essentially how long people live based on the poverty of their neighborhood. In an ideal world, this would be a flat line, and how poor your neighborhood is wouldn't predict how long you live. But we don't live in an ideal world. We live in a world where there are consequences to living in a poor neighborhood, and those consequences can be measured in the length of your life. Sometimes we refer to this as a death tax. We did the same analysis for the entire San Francisco Bay Area, which includes San Jose. And then we did the whole analysis for the entire state of California. And so the slope of that line holds meaning. And we've yet to find a place with a flat line. Yet I'm going to show you some data that's very interesting right now. So we did the same analysis for 7 California counties. And you can see Alameda is the top left, and you can see Santa Clara is the bottom one on the left, that brown one. So that includes San Jose. And this is, again, life expectancy against neighborhood poverty. And you see the relative slopes of those lines. We decided we would go work with the Canadian Agency for Public Health and look at 9 corresponding metropolitan areas in Canada, which include Calgary, Edmonton, Montreal, Toronto, Vancouver, Ottawa. And you can just see sort of like the difference in the slopes of the lines in the Canadian metropolitan areas. Again, these are California counties. These are Canadian metropolitan areas, which are the equivalent of counties. Just to make it simpler for you, we aggregated all the California counties up top, the 7 that we looked at. And at the bottom, you see the aggregation of the 7 Canadian metropolitan areas. And you just see a dramatic difference in the slopes of those lines. So as you move from relatively wealthy communities to relatively poor communities, life expectancy in California gets shorter. In Canada, it gets shorter too, but almost imperceptibly so. Okay. In California, we decided you couldn't put a scatter plot on the front page of the paper, but you could put something like this. Every additional $12,500 in household income buys you a year of life in the San Francisco Bay Area. And we did similar things for other communities across the country. All right, let me pivot to this question because, you are all very sophisticated public health actors, but most people think the United States is the healthiest country in the world. It is not, and it's not even close. We know that we spend on a per capita basis, on a per person basis, more money on medical care than anybody in the world. In fact, we spend twice what the average a developed country spends. That's us on the far left. A couple of health services researchers, two women, two brilliant women, by the way, did something that none of the male health service researchers had thought to do for 40 years of studying this phenomenon. And they took that same data that I just showed you, which is per person spending on medical care, and they transcribed it here in this graphic in that blue line. That's per person spending on medical care for each of these developed countries. But they added to it per person spending on social services and benefits. In other words, they quantified the investment in the social contract across these countries. And when you do that, the United States is no longer the big spender. In fact, we're kind of average. We spend about the same as everybody else on these two critical elements. Our problem is that we have our accent on the wrong syllable. We spend disproportionately on medical care, and we underspend on social benefits and services. And what they found was that those countries, and this is in their book, The American Healthcare Paradox, those countries that spend roughly $2 in social services for every $1 in medical care have the best health. So if you want better health, spend more on social services and benefits, i.e. spend more on your social contract. In the United States, we spend about 55 cents on social services and benefits for every dollar on medical care. So this is Elizabeth Bradley and Lauren Taylor doing a TED Talk, and this was their data. You can read their book. You can look at these slides. These are the benefits that they're talking about on the left. And again, the OECD countries, developed countries around the world, spend roughly twice what they spend on medical care on these benefits and services. The US spends only about 55 cents on the right. Their study was replicated by the RAND Corporation that found that not only were Bradley and Taylor right, they were actually even more right than they thought they were. They went further and they looked at it by US state. I'm going to go quickly over this. This is just one of the graphics from the RAND study from 1980 to 2010, and they show in the bold lines, they show social spending in the EU, which is in the orange, and in the blue, in the US, which is in the blue. And you see for that 30-year period, this gap between social spending in the European Union and the United States. That's a fixed gap across that entire span. And the faded lines is life expectancy. European Union life expectancy in the faded orange climbed. It starts at roughly the same spot where US life expectancy starts, but over that 30 years, it pulls away from US life expectancy, and US life expectancy lags, and that gap continues to grow. And then sort of the converse with the dotted lines is medical care spending. You see US medical care spending shooting up, pulling away from European Union medical care spending. So we literally have the accent on the wrong syllable. This is some similar data, more recent data by Kaiser Family Foundation showing exactly the same thing. And with respect to life expectancy compared to comparable countries, we just keep falling further and further behind. In fact, we've fallen off the trajectory of developed countries. We started in the 1980s, kind of like, comfortably in the midst of those developed countries. And then we just started to just lag, and we lagged the rest of the world, and that lag is getting worse. So Rand's conclusion was that higher levels of social spending are strongly associated with better health. The association is particularly strong for public, i.e. government spending, as opposed to private social spending. And then they go on to say that the association between spending and health outcomes is strongest where income inequality is the greatest, in places like the United States. And then these same associations hold across the states within the United States. In other words, those states that spend more on social benefits and services have better health, like California, by the way. All right. People used to tell me, well, Tony, you got this all wrong. Our problem is health disparities. And if you just took people of color out of the equation, you'd see that the United States has the healthiest population because whites are the healthiest population in the world. And I was like, well, that's interesting. Let me make some more slides. Okay. So life expectancy for US whites is about 79 years. It's actually dropped a little bit over the past few years. And then COVID really put a dent in everybody's life expectancy, dropped it by 2, almost 3 years in some instances. But for, pre-COVID, US white life expectancy was 78 plus years, rounded up to 79, about the same as Turkey and Estonia and Croatia. But US whites are living shorter lives than people in the Maldives, Peru, Belgium, Chile, Costa Rica, Denmark, Greece, Slovenia, the UK, Austria, of course, Canada, Finland, Germany, Iceland, Ireland, Luxembourg, Malta, Netherlands, New Zealand, Portugal, Sweden, Australia, Cyprus, Israel, Italy, France, Norway, South Korea, Singapore, Spain, Switzerland, and Japan. There are 32 countries in the world that have higher life expectancy than US whites. In 1990, there were only 17. US white life expectancy is falling so fast that many health disparities researchers no longer use whites as a benchmark. It's too low a number. We're better off using immigrant Latinos or immigrant Asians, or in fact, immigrant anybody. All immigrant groups in the United States have better health status than their native-born peers. And the crazy thing is, as they acculturate and become more American, their health gets worse. America is not good for your health. Don't believe me. This is the Institute of Medicine, or now the National Academies of Medicine, published this report in 2013 called Shorter Lives, Poorer Health. And trust me, when your title is Shorter Lives, Poorer Health, the news isn't going to be good. And this was their conclusion. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The US health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor. Several studies are now suggesting that even advantaged Americans, those who are white, insured, college educated, or upper income, are in worse health than similar individuals in other countries. If we were together in a room, I would ask some of you how many of you knew that, and then I would push you to explain it. There's more data here. I'm going to skip through this pretty quickly. It's interesting for anybody who's really interested in the data. This is the latest data. This is the National Bureau of Economic Research. And they looked at US whites, US blacks, and Europeans in general. So the US blacks are the red line, the US whites are the blue line, and the Europeans are the black line. And they stratified by poverty. So they did, this is now a mortality rate as opposed to a life expectancy. So the slope is going to be the inverse of what I showed you on the earlier graphics. And they looked at 1990, 2005, and 2018. And what you see is the red line is getting closer to the blue line over time, which means that the African-American mortality rate and the white mortality rate, the gap between those two has been closing. It's been closing dramatically. COVID is actually going to open that back up again because of the structural disparities that have been rampant in COVID. But what I want to show you actually is the sort of the more interesting aspect of this is really this phenomenon. So you see the wealthiest segment of the white American population, which is in that far right graphic on the blue line. You see that their mortality rate is actually higher than the mortality of the poorest Europeans. In other words, our most advantaged and privileged white populations have worse health than the poorest Europeans. And this is the first time that those two lines have essentially changed places in this analysis. So the National Bureau of Economic Research says white health sucks. Okay, so let me move to the next slide. And this is essentially PBS asking the question why so many white Americans are dying young, the Wall Street Journal asking the same question. A phenomenon called deaths of despair has hit the white population, not exclusively white, but disproportionately, and it's alcohol-related organ disease, overdose, and suicide that's driving this dramatic decline in white health. The term deaths of despair was coined by these two people, Angus Deaton and Ann Case at Princeton. Angus Deaton won the Nobel Prize in Economics in 2015 for something that many of us had been talking about for many years, by the way. So it was sort of like, where's my stinking Nobel Prize? They're a married couple, and they produced this graphic, which is basically mortality rates over time stratified by different populations. And you see a general trend from 1990 to 2010 in declining mortality rates, except amongst US whites. And that's that sort of bold red line at the top, where you see not only a failure to decline, but actually an increase in mortality rates amongst that population. This phenomenon is unique in the world. US whites are actually experiencing a mortality crisis that is not being replicated anywhere else in the world that we can understand. So for those of you who had thought that the problem was disparities amongst racial minorities, which is a problem, the underlying health of the United States as a whole is terrible and getting worse. Okay, so my job is to essentially shout this from a mountaintop. These are real zip codes, real life expectancies, and real zip codes and high school graduation rates. When Sacramento redid its airport, we actually decorated the walls with these images so that legislators started calling me, asking me why I was decreasing property values in their districts. This is downtown San Francisco during APHA a few years ago. We festooned the Metreon building with these images. This is San Diego and recent APHA with similar images. So I want to get to a conclusion here so we can start talking. We know that 80% of what influences your life expectancy has nothing to do with doctors. And why? Because we know that essentially there's this concept of allostatic load. Allostatic load is basically chronic stress. And chronic stress actually takes what's happening in your environment around you and drives it under your skin and changes your physiology. And that's basically what's causing people to die prematurely. And chronic stress can take any number of different forms. Some of the more unique to America ones are being socially isolated, experiencing racism, and experiencing high levels of crime. But there are all sorts of different stressors, all of which are amenable to policy fixes. There are all kinds of stressors that exist that are uncontained, that are disproportionately impacting people in those neighborhoods that I showed you that have low life expectancy. And they also have spillover effect to all of our neighborhoods. Nobody is exempt from this phenomenon. Stress affects the body by stimulating the hypothalamus, which sends a message to the pituitary gland, which sends a message to the adrenal gland, which releases a cascade of hormones, of which cortisol is one. In the acute stress period on the left in the blue, cortisol is good for you. It stimulates cardiac output. It rallies glucose for your muscles in case you need to fight or flee. It stimulates your immune functions. It turns down inflammation, and it causes the growth of neurons in your hippocampus and prefrontal cortex, which are critical for what's called executive function. However, when you're constantly bathed in cortisol, like people living in our essentially low-income stress incubators, cortisol does the opposite. It stimulates hypertension and cardiovascular disease. It causes glucose intolerance, puts you at risk for type 2 diabetes. It causes more inflammation, and it decreases your immune response, makes you at risk for greater risk for things like COVID-19, and it causes atrophy and cell death. That same part of the brain that I told you was responsible for executive function. Executive function is basically like triage. It's the ability to make sort of decisions between very different kind of options and find the right tool for the moment that you are in. So people that are chronically stressed out, living in neighborhoods that are devoid of many of the critical resources that we need for health, are physiologically different than people living in other neighborhoods that have access to resources. Not only are they physiologically different, they may pass on that difference to their children through epigenetics. And we could delve into that in the Q&A. It's fascinatingly horrible. All right, so let me conclude with a framework. This is called the Barhai framework, or we just call it a health equity framework. It's basically a way to just sort of understand, what do you do about this stuff? And it starts with sort of the right side of the framework, which is the medical model, which talks about risk, disease, and death. And it shows you where you have opportunities to intervene. On the risk front, you can intervene through health education and trying to improve what people know. On the risk and disease front, you can provide healthcare access, typically in 15-minute increments in a cubicle. Nevertheless, you can provide interventions there. And you can tinker with people's genes at great expense with relatively little benefit. And we've done that in the healthcare system. This is a $3.8 trillion enterprise. It's focused on individuals, and it's a highly technocratic enterprise. And that's where we spend our money in the United States compared to other developed countries. But we've argued that that is all important, but it's insufficient to really improve health. You've got to look at the socio-ecological context, look at where families and communities are operating. And here we have a very different set of drivers. Here we're talking about a set of discriminatory beliefs about who is valuable, who matters, that create policies and actions of institutions, both government institutions and private institutions, that collectively steer resources towards favored people and away from disfavored people. There's a buffer of family and culture, and we see immigrants, again, coming in with very good health, and the first generation's doing quite well health-wise. But as that buffer starts to break down and the family and culture protections start to fade, their health actually gets worse. So the world of health disparities is downstream. The world of health inequities is upstream. You can take the word health out and just talk about inequities producing disparities. Or if you're simple-minded like me, you talk about conditions that create consequences. We spend $3.8 trillion in the consequence management or damage control part of this graphic, and that is stupid and wrong. And most of the world recognizes that and doesn't do it. This is about working in the democratic space to rebuild our social contract and create policies that buffer against the need for downstream intervention in the technocratic space. That's what public health is. Public health has to recognize that interplay between the democratic and the technocratic and be able to intervene in the democratic space. And that intervention has a lot of different components. And first, I want to say that it's not just health that is impacted by this. You see this in the educational space, you see it in the employment space, you see it in the criminal justice space. The argument is to spend less attention downstream and think about what you can do upstream. And what we have focused on in California is simplifying the upstream opportunities into 3 domains: around narrative, around policy, and around place. The goal of this work is to organize people in place, to build their power so that they can participate more effectively in the democratic processes that shape policy and create narrative. That's the name of the game. It's people power that changes this cascade of upstream inequity to downstream disparity. So I'm going to stop there. Just point out that the costs live downstream and actual health is generated upstream through a strong social contract. Let me stop sharing, and hopefully we have some time to have a conversation. Let's see, stop share, that's what I should do best. Okay, there we go.
Excellent. Thank you so much, Dr. Iton, for your informative and engaging presentation. We definitely have some data nerds in our audience that are super geeking out. But before we start the Q&A, I would like to turn it over just really quickly to our Dean of the College of Health and Human Sciences, Dr. Audrey Shillington.
Hi, Dr. Iton. Thank you so much. I'm glad this is being recorded because I'm gonna have to go back and rewatch this. I know that I don't want to spend a ton of time talking right now. I just want to kind of say that some of your work are things that have paralleled what I've done across my career, and I'm just so grateful for the kinds of sort of paving the way for our enhanced, not even enhanced, but new paradigms of understanding in the areas of public health and social work and healthcare and preventative efforts. I was really impressed. I've read some of your literature in terms of building healthy communities, and what I really appreciate is the focus on community, right? Not blaming the individual, but also being able to focus in on policy change and how do we have these broader, deeper, more impactful efforts. So I know that time is short and lots of people have questions, but I hope I have an opportunity to meet and speak with you again. Thank you for being here.
Thanks for having me.
Thank you so much, Dean Shillington. All right. Well, in that case, I know that Dr. Iton is excited to have conversation with us. So we would love for you to use the Q&A feature through Zoom. Unfortunately, we will not be able to get to everyone's questions in the remaining time that we have, but the panel will do our best to organize questions and let you know which ones are going to be answered during this session. So let's see what we've got going right now in our Q&A. All right, we don't have any questions, but I want to start with a question since while you all think of questions. So Dr. Iton, how do we change the narrative? How do we do this?
Yeah, so there are great examples of this that happen right here. Some of your students have probably been involved in some of these efforts. And I'll give the example of Health for All. In California, a very successful campaign around Health for All has driven significant policy change that's created access to full scope Medi-Cal for all undocumented Californians. The only state in the country that makes that the case. And we're the same state that in 1994 had Prop 187. Prop 187 was an anti-immigrant ballot initiative, which passed with 60% of California voters supporting it. And it denied access to public school and all public benefits for undocumented Californians. So between 1994 and the present, it's a little bit less than 30 years, we've moved from a state that had essentially a Trump narrative that was promulgated by the governor at the time, Pete Wilson, and some right-wing kind of conservative people that successfully passed policy to deny undocumented people and children even basic services like school. It got tied up in the courts, as you know, and it was ultimately invalidated to move to 2010, 15, 20, where we now have full scope Medi-Cal coverage for undocumented people. And that was driven largely by the people impacted, people that told their own stories. As I said, the narrative of inclusion changes the narrator and lets people tell their own story. So we saw undocumented Californians driving a campaign called Health for All, which led to significant policy change, several bills actually that were ultimately named Health for All. First covered children who were undocumented under the age of 18, and then to achieve parity with the Affordable Care Act, went up to age 26, and then covered people over the age of 50, and then 26 to 50. So we have universal coverage. The only exception right now is undocumented people who make more income than the Medi-Cal threshold. In other words, they normally would have been either able to get healthcare through their employer or through the exchange, which the Affordable Care Act set up. But as we all remember, part of the policy limitations on the Affordable Care Act was that undocumented people couldn't avail themselves of any of the benefits of that. California is now developing a workaround for that to allow people who can't qualify for Medi-Cal, who have immigration issues, to still be able to buy healthcare privately off the exchange because they have the resources to so do. So that's an example of a narrative flipping from anti-immigrant to pro. And I wouldn't even call it pro-immigrant. I would call it, pro-Californian. Recognizing that our fates are inextricably intertwined and that, undocumented folks are our neighbors, our friends, our husbands, our wives, our colleagues, our classmates. In them, we see our shared humanity. That didn't happen by accident. That was work to change the narrative. And we've done similar things in incarceration space. We've done similar things in housing, although there's work to be done there about whether housing is a privilege of wealth or a human right. But narrative drives policy, policy creates conditions. And so if you want to change conditions, you don't just start with policy, you have to work on the narrative.
Excellent, thank you so much. We've got a lot of questions now from students and from faculty. I'm going to start with a question from one of our students. What should public health students do to promote change? Like, what is their role in promoting change?
Well, I teach at Berkeley a course on public health advocacy, and we teach it very expressly for the reason that this questioner is raising, which is, what can I do to make change? And the truth is, public health students are just so perfectly situated to make change because you have access to the data and the science and the research. And the only question is, how do you translate that into policy? So what we do is basically teach translational public health, to take that science and translate it into actionable policy. And we teach people the skills to essentially make that policy change. And that advocacy has a lot of different features to it. You don't have to be a lobbyist to do it. There are all kinds of roles for advocates that don't involve necessarily walking around in the halls of the legislature, although that is one big part of it. So get involved. You have credibility as a public health student, somebody who has some expertise, and there are all kinds of avenues for public health advocacy, particularly in the San Francisco Bay Area, because we have a sort of a glut of resources, organizations that are doing public health advocacy. We even have one called Public Health Advocates. We have the Prevention Institute, we have the Public Health Institute, we have Policy Link. We have a whole host of issue-focused organizations that are working on health insurance, that are working on children's health, that are working on environmental health. So there's a lot we can do, a lot has been done, and there are armies of people who are waiting for you to join them to get her done.
Wonderful, thank you. Our next question is there a possible theory or reasoning as to why the US has not changed its healthcare system after seeing how much better other countries are doing with the Health for All Act?
Yeah, one word, racism. That is the root cause of our failure to create the social solidarity necessary to create universal policies. And, you know, racism hurts people of color. It also hurts white people. Racism has a lot of collateral damage, and it's the failure to see yourself's story and other people's story that means that you don't want to invest in policies and resources that are shared across society. And as I said, when I showed you the Canadian Social Compact, you look for that word universal. Where you find that word universal means that there's a lot of shared solidarity. The United States lacks shared solidarity, as we saw. I mean, I showed you those images of people scaling the walls of the Capitol, driven by this notion of trying to protect for their tribe the resources of the country. And to get past that, we need to build solidarity across groups. There's no way but with solidarity. You have to have that shared sense of common purpose. Otherwise, the society comes apart at the seams.
Thank you. Our next question is, if California is one of the most expensive states to live in, where the life expectancy for people who live in Stockton is about 78, 5+ years less than those living in Irvine, what would happen to their life expectancy if they decided to move to a different state that had a zip code of about 80+ years for life expectancy? Would there be a change?
Yeah, and that study's been done. A gentleman by the name of Raj Chetty has done this analysis, and it's beautiful. He used 50 million US tax records to show what happens when people move. And the answer is, it depends on when you move. If you move as a child, generally before the age of about 12, you actually adopt the characteristics of the place you move to. And essentially your opportunities start to reflect your new environment. If you move, say after age 18 or so, you generally have less of a kind of a benefit from that move. And then there's a gradient all the way from 12 or so to 18 or 20. And so if you want to get the benefit of that move, you're better off moving as a child. That's the sad truth. It's sort of, the other truth is that there's not a lot of social mobility in the United States. And the socio-ecological conditions of the zip code in which you're born are more likely to reflect the socio-ecological conditions of the zip code in which you die. There's very little upward mobility. There's a little bit of downward mobility. What they have shown, in essence, this is Raj Chetty again and his colleagues, have shown that the American dream is dead. It doesn't exist in the United States. In fact, it's twice as likely in Canada as it is in the United States. So if you want the American dream, move to Canada.
Thank you. Our next question is from a faculty member. From a teaching perspective, what do you think what should be top few things that we should teach public health students to help combat these issues and reshape our narrative?
Well, I think two big things that need to be taught, and students need to get a sense of how it operates. One is power building. How do you actually translate, public health science into policy change? And that requires both organizing and advocacy. So students need to have a sense of how to mobilize and organize communities to essentially empower communities, a word I don't love, but to help, kind of develop the power of communities in order for communities to essentially hold institutions accountable for equitable allocation and equitable practices. The second piece is, how do you change the narrative, which is, as I said, an art, and it can be taught and very effectively, as we've seen in California. So schools of public health are, for the most part, and I think San Jose State is different, but I think, the schools of public health are oftentimes busy trying to kind of act like their cousins at medical schools. They're very much about publish or perish, and, they're kind of, they're not relevant to the policy conversations that are happening even around public health in this country. You saw that during COVID. I mean, most of the public spokespeople for COVID protections were physicians, infectious disease physicians, not public health deans or public health practitioners for the most part. And that's because public health schools are not used to being on the front lines of policy, and that needs to change.
Thank you. We have a technical question also from a faculty member. Can Dr. Iton please describe the difference between genetics and epigenetics? Additionally, how are health outcomes as a result of environmental stress, chronic stress, passed down through epigenetics?
Yeah, and I don't know how much time we have, but so I'll give the short answer to this. But it's a fascinating topic, which, hopefully somebody's teaching at San Jose State, because if not, you should. It's incredible. It's fascinating and horrible at the same time. So epigenetics is, genetics is basically, and I'm giving the very simple answer here. Genetics is basically sort of what's passed on by way of genes, chromosomes and the like. Epigenetics is essentially these on and off switches that are associated with essentially chromatin and other forms of essentially the chemicals that are associated with our genes that can either turn on or turn off a gene and leave it on or leave it off depending on the environmental circumstances in which it finds itself. So you see this methylation, you see various different mechanisms that genes use to turn off or turn on. And we need that ability because, quite frankly, your genetic code is not the same thing in your ears as it is in your bowel. So it needs to do different things in different parts of your body. It also responds to signals in the environment. The fascinating part of this, and whoever teaches it, I'm sure would get into this, is that Darwin was wrong. And there was this other biologist at the time by the name of Lamarck, who talked about how the environment shaped sort of genetic inheritance. And he lost the battle against Darwin. Darwin was sort of like, this whole notion of nature versus nurture. That there was this sort of strict sort of divide between nature, which were your genes, and nurture, which is your environment. And we've shown that these two things interact in people, and that they can be passed, those changes that happen driven by the environment in my genes can be passed on to my children through epigenetics. So it's a fascinating topic. It's much larger than anything I can get into right now, but it means that those stressors, particularly allostatic load, changes genetic expression in people's lives, and that they can pass that on to their children. There's a woman at the University of Michigan by the name of Arlene Geronimus, who's done a lot of work on so-called telomeres and telomere length. And telomeres are essentially an expression of how some of those switches are turned on and off, and how cells essentially live or die.
Thank you so much. Now I know we have some of our science nerds geeking out. So thank you. Now we have about just 5 minutes left. So I think maybe 2 questions, if you're okay with that. This one is getting a little bit more on the personal side. My mom is from Compton, and my brothers were born there and raised there for a few years. I was born in better conditions in Burlingame, California. Even though my brothers spent only a few years in Compton, our health outcomes have been vastly different. Why?
Well, again, this is the data that I was telling you about, and you can look this up. Just Google Raj Chetty, R-H-A, last name C-H-E-T-T-Y, and they have this website which shows essentially how people fare when they move from low opportunity neighborhoods to high opportunity neighborhoods, and because and you see differences between siblings. Those that moved at a young age do better than those that moved at an older age in the same family. And it's the socioecological conditions during that sort of critical formative time period of youth and adolescence that shape people's behaviors, their expectations, which is not to say that you're locked in. I mean, there are all kinds of exceptions to this. But overall, the patterns sort of replay themselves very predictably. And so your brothers who spent more time, in an environment where there was high stress and, presumably they internalize that, carry that with them for life. And there may be some elements of epigenetics playing a role as well. It's hard to do this on the sort of an individual level because there are just like exceptions to every rule. But the overall pattern is that environments shape health in a very predictable way. So much so, as I said earlier, we used to say to people in Alameda County, give me your address and I'll tell you how long you're going to live. And I would be right most of the time, not because I'm a genius, but because the patterns that have been created are so powerful that they really do shape people's, health.
Thank you. All right, our very last question is, as someone from Canada, where the social contract is so much better than America, why live here where your life expectancy is at risk?
Well, there's 2 answers to that question. First of all, I grew up in Canada during those critical formative years. So I got the benefit of Canada, during that time period when it was most important. Obviously, I wasn't thinking about that at the time. But the real answer is this is where the fight is. There are a whole host of ways that this country is imperfect. I mean, it's got a lot going for it, obviously. But, health and social policy is not one of those things. And, my job, as I see it, is the Canadianization of California. I would like to sort of create a strong social contract in California. And this is my life's challenge, mine and obviously, many, many others. And this is where the fight is. Canada's got this figured out already. They don't need our help. The US needs help, a lot of help. And every single one of the students in your program are critical to making this a reality.
Wonderful. Thank you so much, Dr. Iton, for spending this afternoon with us, for engaging with us in matters that are just so important and what we do teach, in our programs, in our very classes. So thank you so much. We will be reaching out with a formal thank you. You're getting lots of love in the chat, lots of thank you for fighting the good fight. And hopefully we are going to continue joining you in that fight. So we hope you have a great rest of your afternoon.
Well, let me just say, I just love the students at San Jose State. I've worked with a number of you in our Building Healthy Communities work. I liked you better than I liked the Berkeley students. Don't tell them that. But you guys are trained to actually do practical things to make change and not just publish papers. So keep that up. Stay in the fight. Keep seeking out opportunities to do this work. And people recognize your skills and your talents, and we will continue to engage you.
Thank you so much, Dr. Iton. Those are inspiring words to leave with us, and we will continue to do so. Have a great rest of your day. Thank you.
Thank you.
Goodbye, everyone.